RN link presents HCCs in the inpatient setting. One continuing education unit available by clicking or copying the link on the description. CEUs accepted by BRN, AHIMA and ACDIS. Learning objectives. At the end of this training session, the CDI Specialist will be able to define risk adjustment, risk scores, hierarchical condition categories, HCC, and PSI 90. Specify examples of common risk variables. Review examples of HCCs, example 30-day readmission diagnoses, understand data analytics and how it is applied to the risk adjustment scores and how to reduce risk within the inpatient setting. See Appendix A, CMS HCC Listing version 28.0. What is risk adjustment or risk scores? Risk adjustment. 1. Levels the playing fields between patient outcomes and the risk among specific patient groups. Example, demographics like age, sex, eligibility. And comorbidities like chronic conditions. Examples are CAD, CHF, COPD, pulmonary fibrosis, osteoporosis, multiple sclerosis. 2. Importance of risk adjustment. For accountable care organizations, ACOs. Examples are Medicare and commercial. 2. Medicare Advantage plans. 3. Value-based purchasing, VBP, for hospital and provider fee. 4. Improves predictability of costs, quality of care and readmission risk. 5. Used in outpatient setting as well as inpatient setting. Risk Adjustment Scores, RAF. A calculation used to identify the costs of healthcare services to a particular beneficiary base. The higher the risk score is for a particular beneficiary, the higher the healthcare costs will be for Medicare. This is a table of common risk variables for CMS. As you can see, for example, history infection, CMS condition category is HCC 1 and 3 to 5. Description is for severe infection. You can see HCC listing in Appendix A. Number 1 is HIV, AIDS. Number 3 is central nervous system infection. Number 4 is tuberculosis and number 5 is opportunistic infection. Let's go to ulcers. CMS condition category is number 148 and 149. On Appendix A, number 148 is decubitus ulcer of the skin and number 149 is chronic ulcer of the skin except decubitus. What are hierarchical condition categories, HCC? 1. It is a form of case mix index, CMI. It uses math to settle a specific rate so quality of care can be isolated, understood, and compared. It is a big part of VBP. HCCs place patients into different buckets, categories, based upon the diagnosis codes submitted on claims. These buckets group patients from clinical patterns and from similar cost patterns. More predicative of readmissions and future costs than MSDRGS. 2. Used for payment methodology. CMS HCCs set capitation payments to Medicare managed plans. In combination with fee for service, FFS, to compensate ACOs. Risk adjusts cost and quality measures for VBP of both hospitals and physicians. Example, risk adjustment in the value-based world. Medicare Part A, 30-day all-cause hospital readmission measure. 30-day readmission examples. Diagnoses include AMI, heart failure, pneumonia, COPD, CABG, total hip arthroplasty/total knee arthroplasty. Review hospital claims from the year before hospitalization, and any secondary diagnoses from admission are used for risk adjustment determinations. It mapped to a subset of CMS HCCs for beneficiaries 65 years of age or older. HCC models. 1. HCC Medicare Advantage, which includes seniors and particular disabled populations. The prospective model uses data from a base year to predict enrollee healthcare costs for the following year. Diagnosis codes map to HCC conditions categories. Hierarchies assign numerical value, which translates to a risk adjustment factor, RAF. Risk determined each year. Regulated by CMS. 2. HCC HHS. Affordable Care Act ACA includes adults, children and infants in individual as well as small group plans. Concurrent model, which uses data from the current benefit year to calculate enrollee healthcare costs in the same year. Total of 15 models are 3 age groups: adult, child, infant, within 5 metal levels: platinum, gold, silver, bronze, catastrophic. Diagnosis codes map to HCC-HHS condition categories. Regulated by HHS and state. 3. Chronic Illness and Disability Payment System, CDPS. Medicaid Chronic Illness and Disability System, CDPS. Diagnosis carry a value for risk, high, medium or low. CDPS and Medicaid prescription, MRX, work by mapping diagnosis to a group of diagnoses categories. The map to 58 CDPS categories for disease and 45 prescription categories. Regulated by the state. HCC revisions. As you can see on the slide, the differences on version 24 and version 28. Version 24 had 86 HCC categories, while on version 28, it has 115 HCC categories. Also on version 24, it had 9,797 diagnosis code mapped to an HCC, while version 28 has 7,770 diagnosis codes mapped to an HCC. Why the changes? Per CMS, finalizes an important transition to an updated risk adjustment model that implements a set of common sense, clinically based technical updates needed to keep MA payments up to date and to improve payment accuracy to MA plans. On this slide is the 2024 HCC updates. Vascular diseases. Added, PAD with rest pain, ulceration, and/or gangrene. Metabolic diseases. Added, Fabry disease, Gaucher disease, Hurler syndrome, and lysosomal storage disorders, i.e. mucopolysaccharidosis. Heart diseases. Expanded heart failure diagnoses based upon stage and severity of the disease. Blood diseases. Added coagulation defects, hemorrhagic disorders, purpura as well as nonspecific immune disorders. Kidney diseases. Split CKD stage 3, 3A and 3B into different categories, deleted dialysis status and acute kidney failure from the categories. Neurological diseases. Added CDIP, chronic inflammatory demyelinating polyneuritis, and multifocal motor neuropathy, expanded myasthenia gravis into acute exacerbation and non-acute exacerbation. Diabetes conditions. Switched, diabetes with unspecified complications and complication associated with blood sugar control moved to lower HCC payment model. Severe acute complications related to glycemic control moved to higher HCC payment model. Psychiatric conditions. Included schizophrenia, psychosis, personality disorders, and bipolar disorders. Musculoskeletal conditions. Rheumatoid arthritis and lupus split into separate HCC categories based upon severity, chronicity, and progression of the disease. Sjogren's syndrome and polymyalgia rheumatica moved to non-payment HCC model. Using data analytics with HCCs. 1. Examination of healthcare patterns. To improve clinical care. Limit excessive spending. 2. Goals. Optimize reimbursement. Decrease financial risk. Improve care planning to reduce follow-up visits. 3. Components. Health plan data, membership, claims, prescription drugs, health plan data systems, diagnoses, pharmacy, lab, DME, patient surveys, care management. Clinical algorithms, reported comorbidities past/present, pharmacy data, lab results, prior authorizations, DME. Computer models, systems that identify specific conditions and group them into buckets. Once comorbidities/chronic illnesses are placed into buckets, mathematical processes rank each comorbidity/illness actuary role. Then, the comorbidities are mapped to providers/physicians based on specialty that will produce the most documentation to support coding of each comorbidity/illness. Building data analytics into risk adjustment program, CDI role. 1. Appropriate reimbursement to compensate for financial risk associated with sicker patients. 2. Identify health initiative patients, PSI, core measures. 3. Better risk identification and closure of HCC gap. 4. Strategies to close HCC gap by optimize MSDRG assignment. Optimize APRDRG, SOI/ROM. Ensure to clarify all SOI/ROM data points. 42% of CMS HCCs are not CCs/MCCs. On this slide are the HCC disease group examples. Infection, neoplasm, diabetes, metabolic, liver, GI, musculoskeletal, blood, substance abuse, psychiatric, spinal, neurological, arrest, heart, cerebrovascular disease, vascular, lung, eye, kidney, skin, injury, complications, transplant, openings and amputation. An HCC coder is not expected to memorize all the diagnosis codes that map to the HCCs. However, there are common categories of HCCs seen in any of the risk adjustment models. ABCs of HCCs, diagnoses to watch for. Arrhythmias. Amputation. Breast, prostate, and other cancers. Body mass index / morbid obesity, congestive heart failure. Chronic obstructive pulmonary disease, diabetes mellitus with or without complications. Depressive disorder, major, single episode or recurrent / moderate or severe. DME incremental compensation with comparing conditions example. Incremental payments associated with DME utilization. Base year DME HCC. Oxygen has incremental payment of $6,907. CPAP/IPPV/ nebulizers has incremental payment of $2,285. Patient lifts /POVs, beds has incremental payment of $7,688. Wheelchairs, commode has incremental payment of $4,382. Walkers has incremental payment of $1,995. Check out the comparison with HCC diseases without DME on this slide. How to incorporate risk adjustment in PSI 90. PSI measures the hospital's quality of care for adult patients. Components of PSI 90. PS03, pressure ulcer. PS06, iatrogenic pneumothorax. PS08, in-hospital fall with fracture. PS09, perioperative hemorrhage and hematoma. PS10, physiologic/metabolic derangement. PS11, postoperative respiratory failure. PS12, perioperative PE/DVT. PS13, postoperative sepsis. PS14, wound dehiscence. PS15, accidental puncture and laceration. For each PSI listed in prior slide, there are two mechanisms used to complete the risk adjustment rate. 1. Exclusions, absolute risk adjustment. 2. Risk factors defined by Agency for Healthcare Research and Quality, AHRQ. Example, PS03, pressure ulcer. Exclusions, LOS less than 3 days, transfer from hospital, SNF, or ICF, MDC14, pregnancy, childbirth, puerperium, any listed diagnosis of hemiplegia/paraplegia, quadriplegia, spina bifida, anoxic brain damage, POA major skin conditions. Risk factors, hypertension with complications, COPD/pulmonary fibrosis, DM with and without complications, neurological conditions, renal failure, AIDS/HIV, hypothyroidism, anemia deficiencies, weight loss, drug abuse, psychiatry disorders, presence of solid tumors without METs. How to reduce risk exposure. 1. Documentation of chronic or acute on chronic is critical to reduce risk. 2. Chronicity of any condition impacts the patient's health over longer period of time. 3. Avoid the use of abbreviations. 4. Include all diagnoses from admission to discharge, condition ruled out, resolved, ruled in. 5. Documentation of history of undergoing current treatment would be considered a chronic condition. Examples: systolic/diastolic/combined heart failure, acute, chronic, acute on chronic. Renal insufficiency, underlying CKD with specific stage. Cor pulmonale, acute, chronic. Bronchitis/COPD, acute, chronic, acute on chronic. Respiratory failure, acute, chronic, acute on chronic with underlying cause. Hypertension, always document cause/effect or underlying cause. Malignant neoplasms, list manifestation associated with neoplasm, document primary site, metastasis sites, recurrence, ongoing treatment. Commonly missed diagnoses: major depression, protein-calorie malnutrition, dementia, obesity/OHS, obesity hypoventilation syndrome, COPD, manifestations of diabetes, status of amputee, CABG, stents or organ transplants. These are the references used for this presentation. The next 3 slides are the appendices for CMF HCC listing for your reference. Thank you for watching. Don't forget to click subscribe, follow and like buttons to get the latest updates. For $40, click or copy the link below for 2 hours continuing education.